about tonight is delegation of nursing care, and then we're going to start respiratory and get as far into the respiratory content as we possibly can. So the first thing I'm going to have you do is, on the back of a piece of paper. Okay, we're still recording. I hit the wrong button there. What I'd like you to do is to jot down the answers to these questions. Are you able to ask others to help you, or do you need to do every task yourself? If you ask someone to do something, do you check to see if the job was completed? How do you think these responses can and do affect your ability to delegate? And what barriers to delegation might you face as a new RN? So just kind of jot those down, and then we'll talk about the whole concept of delegation and how maybe you're what?
You just want us to write out response.
Yeah, just jot down how you would answer those questions, and then then I'll ask for some people to volunteer their responses. So it's, are you able to ask others to help, or do you need to do every task yourself? If you ask someone to do something, do you check to see if it was completed? How do you think these responses are going to affect your ability to delegate, or maybe you already have when you've had your 2-patient assignment? And then what barriers might you encounter as a new RN? So I'm going to kind of rephrase that first question and ask, how many of you were the type of people that could not ask people to help you before you started nursing school? You had trouble delegating like housework and other tasks. Gee, not that many. The day class was full of type A's, of people that, just could never delegate. So those of you who had trouble delegating before you started nursing school, is it easier for you now? Have you kind of lowered your standards a little bit, maybe? Yeah. They still never do it right, but your standards have changed. So so those of you who had trouble delegating, you probably used to kind of go around and if you did delegate, and check up on them, and then if they didn't do it right, you had to redo it, and and then after a while, it just was easier to do it yourself. So if that is your problem, or if that is your personality trait, hopefully nursing school has knocked some of that out of you, because delegation is going to be crucial when you get into practice, and if you can't delegate, you're going to burn out in 6 months, and that's a huge issue with new grads, is that those first 6 months to a year, you have more new grads leaving the profession because they burn out, which is really sad after all the time and money and effort and everything that you've put into a nursing degree, to just not be able to cut it because you can't delegate. So how do you think you're going to be able to delegate? Have you encountered any problems delegating, like when you've done if anybody's done a 2-patient assignment yet? Cindy, did you?
No. Well, the person I was working with, we worked really well together, and that worked really well. But in the past, sometimes the CNAs kind of gave us an edge because we're just student nurses.
And that's why we got those the senior nursing student pins, because it was an issue a few years ago where they were getting pushback from the techs because they were used to all the other nursing schools and our students in the earlier semesters doing everything for the patients, and so they were resentful when you guys were asking, were trying to delegate because you were learning the principles of delegation. So that's where that, that differentiation kind of, that we hope that the pin would kind of help that, but you're still kind of getting a little bit of pushback.
When we were at Johnson, I found that the CNAs, if you were there, they disappeared. You didn't see them all day.
Yeah.
So if you did need help with something, you had to to like chase.
Yeah, well, you were on the second floor. If you'd been on the third floor, you wouldn't have found that. Because CNAs didn't, yeah, CNAs didn't do that to my students. But anyway, so as a new grad, what kinds of barriers to delegation do you think you might encounter? What kind of problems?
The fact that you're a new grad.
So what,
You don't have the knowledge and work experience.
older nurses with experience, or older CNAs or techs? So yeah, you know, you're coming out, you're a new grad, and you've got a CNA or a tech that's been there for, you know, 20 years, and they kind of look at you and go, yeah, what do you know? So that can be an issue. How many of you work as CNAs or techs now and plan to perhaps work at the same place? So what kind of barriers might you, Kate, think you might encounter when you become an RN and you start working on the floor where you used to be a CNA or a tech? Right, they're going to have a hard time seeing you in that role. You were their peer. You were you sat around at lunchtime bitching about the nurses and complaining about the, you were all connected, and now all of a sudden you got RN after your name and you're delegating tasks to them. So there could be some pushback and maybe some attitude if it's not handled in the best way. And that's going to be a challenge for you when you get into your new job, is to be able to delegate to the people that you used to work side by side with, and still try to promote that team spirit and not have them be resentful. What other things could happen? Staffing, if you're short-staffed and you start getting overwhelmed and a lot of things are happening and you're still not, I'm going to teach you, some of the principles and concepts of delegation, but until you're in the middle of it and you're looking at the situation, you're looking at the patient, it's hard to remember, and it's hard to get that, to prioritize and delegate. And when it's, when the pressure is on and the time is running out, there's a lot more pressure. And sometimes you may feel that, well, rather than taking the time to make the decision, can I or can't I delegate, I'll just do it myself, because maybe it'll be quicker that way. And I'll feel safer because I'm not 100% sure. Did you have a comment? And you may, when you get into that new situation, you may feel, okay, people are looking at me, I need to prove that I'm competent, I need to prove that I know what I'm doing, and if I try to delegate off too many tasks, maybe they're going to perceive me as somebody who's not really competent, that I don't know how to do these things. So it's going to be very tough to be able to delegate when you first come out. And that's one of the reasons why we do that two-patient assignment, not just for you to be able to coordinate the care of two patients and have to be thinking about, what's the priority of this patient over that patient, but also being able to look at that caseload that you have and see, okay, what do I not need to do myself? What can I delegate off? So that's always going to be an issue when you're a new grad. So the 5 rights of delegation. Does anybody know what the 5 rights of delegation are? The right circumstances. Let's start from the right task. Because the first thing is you've got a list of things that you need to do. And you're going to look at that task and you're going to say, okay, is this a task that I can delegate? Or is it something that I have to do as the RN? So that's going to be the first question that you're going to ask. And then the next question is going to be, is it the right circumstance? And that's really important to know, because there may be a task that normally you would delegate under normal circumstances, but maybe the situation, the patient acuity, what's happening on the floor, staffing, safety, there's a lot of circumstances that can impact that decision to delegate. So the example I like to use for that is you've got a patient on med-surg floor that's relatively stable. You delegate the morning ADLs, the turning and repositioning of the patient, washing and all that other stuff without a problem. That's perfectly safe, and you're comfortable doing that. But then you go into a critical care area or someplace like 10-9 where some of you are doing your clinicals. And you've got a patient with a chest tube, and they're on a vent, and they've got a central line and an A line, and they've got, a Foley catheter and an NG tube. That turning and repositioning and cleaning up that patient is not going to be safely delegated to the tech or the CNA, because there's a lot of risk for things to happen and potential complications. So that might be a situation where you would go to the tech or the CNA, grab them and say, hey, let's go wash up Mr. Jones, so you're there when all of that process is happening and the patient's being turned, and maybe the endotracheal tube gets out of position, but you're there and you can correct it and you can assess any probable complications. So the task could be something that's legally something you can delegate, but the circumstances dictate, your nursing judgment says not a safe thing right now. And then the right person. Is this the person you can delegate this task to? Is it in their scope of practice? And we're going to talk in a little bit about the different scopes of practice between the registered nurse, the RN, the LPN, and the UAP. And you're all familiar with that term UAP, unlicensed assisted personnel, because that will come up on an NCLEX question. They won't talk about techs or CNAs. They refer to them as UAPs. So is it in their scope of practice? And then there's the right direction and communication. How you communicate what needs to be done, explaining what needs to be done, the time frame and all of that, so that the person who's doing the job knows exactly what your expectations are, knows what other, what side things and concerns and issues that might be a little bit different this time. You've explained all that. So you're ensuring that they're going to go out and do the best job possible and do what you need done. And then the last one is going to be the right supervision and evaluation. Because a lot of you come up with questions, well, what if I delegate and they make a mistake? Am I going to be held responsible? And that's where, as you begin to delegate and you get more comfortable and you get to know the people that you're delegating to, you'll be spending less time actually going around and supervising and checking up on them, because you'll be confident that they're doing the job correctly. You still have to go around and you have to check, and you may ask them in passing, did you get that blood pressure for me, or did you check that blood sugar? So following up is not a problem, and always knowing that if there is a mistake, that even though you personally aren't responsible for the mistake, you are responsible for correcting it, maybe disciplining or remediating that particular person that you delegated to, if that's your position on the floor, and making sure that the patient is safe and that you followed up. So you've got the right task, the right circumstances, the right person. Are they legally able to have this delegated to them? The right direction and communication, and the right supervision and evaluation. Now, the video I'm going to show you, which is based on the NCSBN position papers on delegation, only talks about 4 rights. They do address the issue of circumstance, kind of in with when they talk about the task and the person. But I think it's important enough of a distinction to list that as a separate situation. Now, there's a couple of links that are going to be very important for you to be able to look at. One of them is the Connecticut State Board of Nursing, the Nurse Practice Act, because that's going to give you a lot of information as to what your scope of practice is as a registered nurse, what's the scope of practice as an LPN, and then they won't really talk specifically about the UAPs, but you will have that. You will have things like job descriptions and policies and procedures to give you that information. So if you really are having trouble sleeping tonight, download this, print it out. It'll be very interesting reading for you. The other one is to go to this link on the NCSBN delegation documents, because these are the guys that write those NCLEX questions. So what they think about delegation is kind of important to know, because they're going to ask you a lot of delegation questions on the NCLEX. And why is that? It's not a bad request. There we are. Okay. They have a couple of PDF files that talk about principles of delegation to UAPs. So these are some of the tools that you can have to help you in your delegation of tasks, I'm going to try to get out of this without losing my recording. There we go. And paused. Okay, so these are the scopes of practice in Connecticut, which in some states may differ. So again, on an NCLEX, you're going to have to be very careful about the things that I'm going to tell you that could be things that you would not be able to delegate to an LPN, and that's in other states where you could in our state. So first of all, the APRN in Connecticut, the Advanced Practice Registered Nurse, and they do have a scope of practice in the Nurse Practice Act for APRNs. In Connecticut, they have a collaborative agreement with a physician. So they are operating basically under the physician's, in collaboration with the physician's license. They do have prescriptive authority, and so they are held to a higher level of accountability in terms of malpractice, like we talked about last week. In some states, certain types of nurse practitioners, APRNs, can practice independently and do not have to have a collaborative agreement with the physician, but in Connecticut they do. APRNs in Connecticut are required to have malpractice insurance, and they're required to get continuing education units, CEUs, for renewal of their license. In Connecticut, RNs collaborate with and under the direction of a physician, an MD, a DMD, or an APRN, a Doctor of Medical Dentistry, or an APRN, and they can also follow orders from podiatrists, because frequently in home care, we would have the patient go for their diabetic foot care, and then the podiatrist could order wound care, and that is something that nurses in Connecticut can follow the orders of those. In Connecticut, RNs are not required to have malpractice insurance, but the majority of your employers will require it, and you would be foolish not to have malpractice insurance after our lecture last week, or Monday when we talked about it. RNs in Connecticut do not need CEUs to renew the license, which, I kind of don't like that, because I think it makes nurses lazy. I think we should always be learning more. Those evidence-based practice, things change. Things are, very different in some areas of nursing practice in the 30 years since I've been practicing. So you really need to keep up with that. Plus, if you decide to go for certification in a particular specialty, oftentimes they'll require a certain, along with a number of hours worked in that facility, that specialty, you'll also need some continuing education to get that in order to qualify to take the certification exam, and also to maintain your certification if you want to renew it. Usually the certifications are good for like 5 years. Most agencies do that. So again, you don't need that to renew your license in Connecticut. If you decide to get a license in Massachusetts, you do need to have CEUs to renew your license. You don't need it for the initial licensure, but we have to get 15 CEUs for every 2 years to renew our license, and we don't have to show proof of it on renewal. We just have to have the documentation available if they randomly ask us to show proof. I know in New York State there's I think it's an infection control module that they specifically have to take, and it's part of the New York State nursing programs. But anybody coming from out of state has to do some sort of a competency in that area in order to get initial licensure. So every state is going to be different. If you're not getting licensed in Connecticut, you need to get on that state board's website where you want to get licensure and find out what their requirements are in terms of if you need any sort of additional modules like New York State requires. So what the RN is responsible for is, as I've already said, is the nursing process. So we are responsible for that initial assessment of the patient, the initial education to begin the teaching for that patient. What we can delegate to the LPN is ongoing assessment, So the LPN can contribute to the assessment, but they cannot do that initial assessment. They can contribute to the plan of care, but they cannot develop the plan of care. That's the responsibility of the RN. In Connecticut, LPNs can receive verbal or telephone orders from the physician. In some states, they cannot. So on an NCLEX question, delegating a phone call to report a change in condition to that LPN, or any sort of task that might require them to get an order from the physician, you would not be able to do, because in some states they're not allowed to take orders from physicians. In some states, again, IVs cannot be done by LPNs. So on an NCLEX question, don't delegate a patient with IVs to the LPN. In Connecticut, Massachusetts, most of the states surrounding here, LPNs do IVs on a routine basis. The UAP, they do direct and indirect care. Non-invasive tasks, ADLs, IADLs, maintaining safety, collecting data. So they can gather the data that you need, but they cannot, in their scope of practice, evaluate what that data means. Now, that doesn't mean that the UAP is ignorant of the fact that a blood sugar of 240 is a problem. But it is not their scope of practice to evaluate that the patient has a problem and do something. But you've worked with techs and CNAs, and some of you are working as techs or CNAs, and you've reported your concerns, obviously, to the nurses. But again, that's not your scope of practice, and for the nurse to totally rely on your report and your analysis of the situation is dangerous, because it's your responsibility as the RN. Even if you totally trust that LPN, that UAP with whatever they're telling you, you need to verify that information yourself before you start making an assessment of what has to be done, and phone calls and changes in the plan of care. So the responsibility is retained by the RN. But as I said in our discussion, if you've delegated properly and legally, and you've given the correct direction, and you followed up and remediated and corrected if there's a problem, then you are not going to be held responsible for someone else's mistake. The only time you're going to get nailed for someone else's mistake is if you delegated something that was out of their scope of practice and that should have been done by you or maybe an LPN, if not another RN. LPNs can delegate to UAPs. They're doing it all the time in long-term care facilities. Most long-term care have an LPN that's in charge of the floor. You've got several aides, you've got 40 patients. Somewhere floating around in that building is an RN. But the LPN is delegating tasks throughout that shift. But they cannot delegate tasks that are within the purview of a licensed nurse, whether it's an LPN or an RN. So you cannot delegate your nursing judgment. You cannot delegate the nursing process. And when it comes to UAPs, you cannot delegate medication administration, including topicals. And that became a huge problem for us in home care. Because in the regulation for home health aides is that they could not apply any prescription topicals. So, a prescription corticosteroid, prescription antifungal. Now, the majority of the time, the reason we had the home health aide in the house was to do, bathing and dressing of the patient, and frequently they would have to put creams or ointments or something on the patient. If it was not a prescription, that was okay. Frequently, what would happen is that because if it was something expensive, and if their insurance or Medicare or Medicaid would pay for that, if it was a prescription, then the doctor would write a prescription for the Eucerin cream, which you can get over the counter. But the minute a pharmacist slaps a prescription label on it, it is now a prescription topical, and the home health aide could no longer apply it to the patient. A simple corticosteroid cream that you can buy over the counter, because it was cheaper for the patient, they wouldn't have any copay if it had a prescription label on it. Now all of a sudden the home health aide couldn't put the the steroid cream on that little rash that the patient had on their back that they couldn't reach They couldn't put it on themselves. It was very difficult a lot of times in managing some of these patients because of those restrictions. But you have to think of the fact that the UAP, in this case the home health aide, is in a patient's home with absolutely no direct supervision by a licensed nurse. So things that maybe a CNA or a tech could do in a nursing home, the home health aide could not do in home care. I mean, I've seen in some nursing homes CNAs giving suppositories. But there's a nurse there. Not sure if legally in a nursing home that was something that they could do, but I've seen it being done and was told that the reason that they couldn't do it in home care was that they didn't have a nurse on site. So delegation is going to change sometimes depending on the area of practice that you're in. But you can never follow, as they said in that in the video, the agency or institution policy cannot supersede what the Nurse Practice Act says you can and cannot delegate. So if they're telling you, oh sure, it's okay, we do it here all the time, and you know that it's not correct according to the Nurse Practice Act, that's time to get your resume out and look for another job before your license gets into trouble. And while you're waiting to get, to work out your notice, make sure that you're not delegating anything that you shouldn't be. So you're responsible, accountable for the care that's given, and delegate on a case-by-case basis. Remember, if the task is something you normally delegate, you still have to ask yourself, based on patient acuity and patient safety, is it safe for me to do it in this situation? You always assess the patient prior to delegating, so that, again, if that situation changes, that could affect what your tasks are. Ask yourself, would a reasonable, prudent RN delegate the activity? Will the activity require any kind of assessment or judgment? Or is it simply a task that can be accomplished? And does it fit those 5 rights of delegation? So, the RN has an LPN and a CNA on the unit. Which patient is most appropriate to give to the LPN? The client with dementia, 1-day post-op mastectomy, client requiring assist with bathing, client requiring assist with ambulation. It will only work once. Oh, it's a special clicker. Okay. Okay, 61% said the client with dementia, 39% said the 1-day post-op mastectomy. So this is a situation where you're looking at, okay, let's get this so the other things are, where you're looking at, they're asking you, which patient are you giving to the higher level of training and expertise. So that means you have to pick the patient that is most stable or unstable? Unstable. So 3 and 4 nobody picked. Those are kind of obvious. It doesn't, those are, obvious things that you're going to be delegating to the UAP. Why would you delegate the client with dementia? What's that? They're all more unstable than the other 2, but the patient is, what is your biggest concern with dementia? They're unsafe, right? There's no other data in that question that leads you to believe that there's any other problems other than safety because there's dementia. So, what's that? So the post-op, it requires more assessment. So that's the one that you would delegate to the LPN. That's the least stable of the 4 patients. Does everybody understand that? Oh. No, you're not talking about it. You say the question is asking you, they're telling you have an LPN and a CNA, and they're asking you, of these 4 patients, which do you give to the LPN, which 3 can you give to the CNA? That's how the question, and those are the kinds of questions that you're going to get. So they're going to ask you, which is safe to give to, which is the safest person to give to, safest patients to give to the CNA as the lowest level of education and training, which is the, so always you just look at, if they're asking about the higher level, pick the most unstable patient. And they're not talking about delegating to an RN. You're the RN, you're delegating tasks to either the LPN or the CNA. Which patient is least appropriate to delegate to the nursing assistant? Assist post-catheterization client required to lie flat to eat lunch, taking frequent oral temps on a client, accompanying a man to his car who is being discharged home, collecting a client's urine specimen. Okay, 53 said the post-catheterization client, 12% said oral temps or taking the guy to his car, 24% said collecting a urine specimen. So here where you're talking is, trying to get rid of these little bars here. You're asking what is the least appropriate patient to delegate to the nursing assistant. So here with the least appropriate patient, so you need to say, okay, which of these patients is most unstable, right? So collecting a urine specimen, is that something you can delegate? Sure. It doesn't tell you anything about the stability of the patient. They're just doing a task. Accompanying the man to his car is being discharged home. Can you delegate that to the UAP? Sure. Taking frequent oral temps? Sure. Why is it not good or not as safe? You know, you normally delegate feeding a patient to the UAP, but you've got a risk. You've got an added risk because the patient has to lie flat, so a risk for aspiration. So this is a situation where a task that you could normally delegate, feeding the patient, is not safe because you've got a risk for aspiration. So that's the most unstable situation that carries the most risk for delegation. Okay, we're going backwards here. Yep.
That's one.
Yep. Okay, you have an RN and an LPN on your unit. Which of the following is the most appropriate assignment? The RN, an unemployed 26-year-old woman newly diagnosed with advanced HIV/AIDS. The LPN, a 41-year-old male 2 days post-op from acoustic neuroma resection transferred from ICU today. The LPN provide discharge teaching about meds and nephrostomy tube care. The RN, 65-year-old admitted for chest pain, being discharged home today with no medications ordered. That's where reading the question is very important. Is it a true option or a false option? It's a scanning thing. That's right. Okay, 53% said the first one, the RN with the newly diagnosed HIV/AIDS. 11% thought the two LPN assignments were appropriate, and 26% thought that the 65-year-old with being discharged after chest pain was appropriate to give to the RN. Why are 2 and 3 not appropriate delegations to the LPN? Yeah, you've got somebody who had neurological surgery 2 days ago, just came out of the ICU today. So if he hasn't had his initial assessment when he came out of the ICU, he'll need that. And even if he has had his initial assessment coming out of the ICU, he's still going to need an RN because he has a higher risk for complications post-op. How about number 3? Why is that not appropriate? It's discharge teaching. Doesn't say anything about teaching having already been done by the RN. So the LPN is not, even though they're perfectly capable and intellectually and all that capable of teaching, it is not in their scope of practice in the situation to do the discharge teaching about the meds and nephrostomy tube. So the majority of you picked number 1. A lot of you picked number 4. Number 4 would be an okay delegation to the RN, an okay assignment to the RN, because it really doesn't give you a whole lot of information. It implies that because there's no medications ordered that there's no discharge teaching, but really there might be some other discharge teaching other than meds. So number 4 would probably be best to go to the RN, so that would be an appropriate assignment. But number 1 is the most appropriate assignment to give to an RN. Why? They're newly diagnosed. So what is that? A lot of education, a lot of assessment, psychosocial coordination of care, referrals to community resources, a lot of care. That has to be done by the RN. That's part of the nursing process. You're setting up that plan of care. Now these I'll read to you because they're really kind of hard to see. You've got an LPN and you've got an RN, and I'm going to read the scenario and you tell me which that you should delegate that patient to, an RN or an LPN. So the first one is Mr. A. He's 59, had an exploratory lap with a permanent colostomy 2 days ago, has an IV, a PCA, indwelling catheter, NG drainage to low wall suction, IV push Decadron. RN, why? You've got IVs. You got a complicated patient. He was only done 2 days ago. Lots of teaching with a permanent colostomy. The next one is Mr. B, 85, had a CVA, left paralysis 1 week ago. Sitter due to confusion. LPN. You've got a patient, a 1 week post CVA. He's out of that 72-hour danger zone that we're going to be talking about when we talk in neuro. And you can have the LPN contribute to the assessment, do ongoing assessments for that patient. There's not a lot of complications that we're worried about at this time. Mrs. C, 35, 23-hour admission for myelogram. Does anybody know what a myelogram is? It kind of is. What it is, it's an X-ray where they inject dye into the CSF to see if the patient has herniated discs. So she probably came in with back pain, and they did a myelogram, and they're sending her home. So that tells me the myelogram was negative. There's no herniated disc, otherwise she'd be hanging around to have surgery. So an LPN. Again, that might be, and if this was on an NCLEX question, it would probably give you a lot more detail. There might be some teaching involved, so maybe it would be appropriate to give to the RN, but just the data that you have there, an LPN could take care of that patient.
Could be delegated to an LPN unless there's teaching.
Right. Right. I mean, the LPN can help the patient get ready. If they've had some teaching, the LPN could reinforce. But as long as the RN has given them the discharge instructions, the LPN could certainly continue on with teaching and facilitate the discharge. Because in this case, you can assume, and this would be a case of kind of reading into the situation, that she's not having any referrals, no medications. The myelogram was negative, so she doesn't have a herniated disc. So she's probably just going to go home and, maybe she's got some Percocet to take. But again, I'm reading into it, and so, at this point, the LPN with what you've got data there. We have Miss D, 29, severe asthma, some respiratory difficulty, on aminophylline drip and steroids. RN. Who knows anything about aminophylline? Not a real common respiratory med. You may have some of your older patients may be on a med called Theodore, which is a longer-acting theophylline medication. And it's an older bronchodilator that has a lot of side effects, particularly tachycardia. Most patients are on different, different better-acting bronchodilators that don't have the severe side effects. Aminophylline, if a person's on an aminophylline drip, they could go into a dysrhythmia very quickly, because it really will make them tachycardic. So if they're on the floor at Johnson, they're always on telemetry. And if they're unstable, they're going to be in the unit because they can go into a dysrhythmia. Mrs. E, a 75-year-old new diabetic, needs reinforcement about insulin administration. Reinforcement. That means that they've had teaching about insulin. The LPN can reinforce that teaching. Read those words. Okay, Mrs. F, 95, admitted from a skilled nursing facility with dehydration, hypokalemia, receiving potassium, 10 MEQs, and 50 mLs of D5W times 3. RN, because? So, oh gosh, I keep going backwards on these things here. So, tell me, what are the 5 rights of delegation? Good. So you're all going to remember that, right? So I have a little, to kind of wrap up our our professional issues, some interesting, a little story about a man that addresses some cultural issues. So I'm going to have you read this, and then I'll ask you some questions about this scenario. Here, I'll give you an extra one to give to Kate. Pass back there, so you don't have to get up and walk all the way over there, because you've worked all day.